welcome to the Alabama Public Health Training Network. A woman's reproductive health is a delicate and complex system in the body. Today we will discuss the issues that are related to health care needs of women. Thank you for joining us today for our program, The Dawning of a New Day, Women's Reproductive Health Update. Our objectives today are to discuss the health care needs of women from adolescence to the postmenopausal period, distinguish between the types of contraceptives available, use and effectiveness, and how we can tailor these to each patient. Define the top-tier methods of contraception and why patients should be encouraged to choose them. Identify how to use the U.S. medical eligibility criteria proficiently for initiating contraceptive methods in public health through the use of case studies. Describe how to talk with patients about sexual coercion and human trafficking, and to outline the options for patients with a positive pregnancy test. If you have a question about anything during being discussed today, please call or email our faculty presenters during our live broadcast. The phone number and the email address are on your screen now and will appear again later in the program. Also, the handouts and the sign-in sheet and evaluation are all available online. You will need to register for this program in order to access those materials. Continuing education credits have been approved for nurses and social workers for today's program. The Alabama Department of Public Health is an approved provider for continuing education by the Alabama State Nurses Association. The association is an accredited provider, approved. The association is an accredited approver of continuing nursing education by American Nurses Credentialing Commission on Accreditation. The ADPH is also approved provider of continuing social work education by Alabama Board of Social Work Examiners. In order to receive credit for this training, you must watch the entire program, then complete and return the sign-in sheet and evaluation. Instructions on how to do this can be found at the bottom of the sign-in sheet. While content may continue to be relevant, the CE credit will only be available for 1 year and will expire November 30th, 2015. There is no financial relationship between the planners of this program and the speakers. There is also no commercial support for this program. ADPH does not endorse any product that may be displayed in conjunction with any activity that might be demonstrated, nor will the department discuss any off-label use of products. Please note that the content of this program is based on the policies and procedures of the Alabama Department of Public Health. By the Alabama Department of Public Health, Alabama and federal statutes, rules, regulations, and guidelines. Viewers are not employed by ADPH should always check for clarity whether the content is accurate according to the statutes, regulations, and policies of your respective jurisdiction or agency. I'm Beth Nichols, the Nurse Practitioner Director for ADPH, and with me today I have Beth Allen and Deborah Davis, both my senior nurse practitioners. Welcome.
Good morning.
Thank you. Good morning. Good morning. Deborah?
Good morning. We want to talk a little bit about the healthcare needs of the woman from adolescent to the postmenopausal period. ACOG, which is the American College of Obstetricians and Gynecologists, recommends that we divide the woman's life cycle into 4 intervals. These 4 intervals help us to organize what our clinical approach is to a woman's care. So we start off with the adolescent, 13 to 18 years, the young woman, 19 to 39 years, the mature woman, 40 to 64 years, and the older woman who is more than 65 years of age. Now, there may be a little bit of overlap to this. The CDC has another definition, and they talk about adolescents as being age 10 to 24. And the reason for this is because of increased risks that may start early and persist throughout the early 20s. According to the CDC, during this stage, there's more violence and suicide, sexually transmitted infections, unplanned pregnancies, and preterm births. The CDC health statistics tell us that approximately 70% of young women may have had sex by the time they're 19 years old, but about 77% of those did not use contraception the last time that they had sex. We know that the U.S. teen pregnancy rate is one of the highest in the world. However, we have noticed a little bit of trend. It's trended downward a little bit in the last 10 years, both nationwide and in the state of Alabama. And this is thought to be the result of the LARC's contraception. So let's define puberty. Puberty is the process of physical growth and development that transitions children to adults. And adolescence means that it's the process of their cognitive, psychosocial, and moral growth and development that transforms dependent children into independent adults. Teen pregnancy is not due to contraceptive failure. Teen pregnancy is due to lack of contraceptive use. So let's talk about what we can do for our adolescents, 13 to 18 years of age. First of all, we're going to screen them, we're going to give them guidance, and we're going to immunize them. This is a critical time to make a good impression as we take care of our young patients. We're going to give them guidance on issues that might pertain to them individually. We're going to tailor their care. As we're screening adolescents, ACOG recommends that we do a height, weight, and body mass index. At this stage of development, we also need to do a blood pressure, an abdominal exam. A pelvic exam, however, is done on an individual basis and only if it's clinically indicated. One thing we have to remember is that it's not tied to whether or not they get contraception. They can get contraception if they do not get a physical exam. If their history indicates that they need a pelvic exam, then we need to do it. We do all of this because of the population that we serve and their disease risk. We educate them because often we're the only provider that they may see, and that's the only place that they're going to get this information. I wanted to mention Tanner staging here. The onset and progression of puberty is highly variable, and the Tanner scale is a uniformly accepted method to describe pubertal changes of breast development and hair distribution. So when the young patient comes in and we don't know exactly how to chart the way that they look, their appearance, it would be beneficial to note their developmental appearance with Tanner staging. ACOG states that Menses is an important vital sign. The menstrual cycle is a hallmark of puberty. In the first 2 years after menarche, the menstrual cycle may vary due to the hypothalamic, pituitary, and ovarian axis getting established and working correctly. The normal menstrual cycle for most folks may vary anywhere from 21 to 35 days. But once this menstrual cycle has been established, anything outside that range would be considered abnormal. And certainly if they have not begun their period by the time they reach 15 or 16, that also would be considered abnormal. Sometimes we do know that if they're like ballerinas or they do a lot of vigorous activity or have severe dieting, that may affect when menarche can occur, and also when their menstrual cycles may tend to be a little more irregular. So the evaluation of the menstrual cycle includes several things. We want to know, first of all, when menarche occurs. We want to know the pattern of their bleeding or the timing of it. And certainly the amount of bleeding is subjective. It's important to get a menstrual history And we also need to look at their previous menstrual history over the last 6 months. We should teach patients how to track their periods. You know, there's apps for everything, and there's an app for this too. Timing would be from the start of one menstrual period to the first day of the next menstrual period, and then how many days their period usually lasts. The American College of Physicians, ACP, recently issued new guidelines recommending against screening pelvic examinations in asymptomatic, non-pregnant women. And I kind of wanted to talk about that as we talk about the Adolescent's pelvic exam. ACOG's recommendation for the adolescent pelvic exam be done on an individual basis, and only if it's clinically indicated. We have to remember that the adolescent patient is a unique patient. If we don't engage them, they may not come back. They're a special population, and it's our responsibility as their clinician to reel them in, so to speak. A key point that we have to remember, again, is that their birth control is not tied to their pelvic exam. If you can't do their exam for whatever reason, then give them their birth control. The patient should receive a thorough explanation about the speculum and bimanual exam and must be agreeable to initiating the exam. When I'm talking to the patient, when I have a new patient who's never had an exam, I usually will stand with them. I don't want to put them in the stirrups first. I kind of put my hand on their hand and I tell them exactly what I'm going to do. I tell them that I have a little instrument called a speculum that I'm going to insert into the vaginal canal and open up so I can see. And they're going to feel a little discomfort when I do that, but it shouldn't be too bad. After I look at everything, I have a little Q-tip that I'm going to swab the cervix, and then I'm going to remove the speculum. And because I can't see your ovaries or feel your ovaries, I tell them, then I need to put 2 fingers in the vaginal canal and press on your belly with my other hand. And this is just to make sure that there's nothing unusual going on there. I also tell them that this is an important exam, but I tell them that if the exam becomes too uncomfortable to let me know, and I'll stop and we'll regroup. And most patients are very agreeable to this exam, and it's very important that we leave a good impression with our patients and not a bad one. Other screening of the adolescent may include looking at blood pressure, their lipid levels, obesity and eating disorders, physical, sexual, and emotional abuse, and learning or school problems. One approach to think about the adolescent psychosocial process is their thought process. We have to remember that the adolescent is consumed with their appearance. And these are important subjects, and we have to broach these subjects with our patients. And to do that, we can tie that to their appearance. We have the highest rate of diabetes in the nation. So we've got to have the discussion with our patients and give them guidance on their health issues. So is there physical, emotional, or sexual abuse? The clinician has to ask the questions. How do we know if there's learning or school problems? Then we have to ask them. We say questions like, do they like school? Do you make good grades? Ask them if they have friends. Ask them if they feel like anybody is picking on them in school. That's the only way we're going to learn whether or not there's other issues such as bullying. As we ask the questions, we ask them if they've ever tried drugs. Do any of your friends use drugs? Ask the patient if they feel sad or if they ever have thoughts of harming themselves or others. We tell them frankly that we have to talk about their sexual practices. Sexual behavior does not encompass just vaginal sex. We do not ask them, are you currently sexually active? Because they take this literally. They think when we ask that question that we're saying right now, this minute. Ask them if they've been coerced to have sex. Does anybody ever make you do things that you're uncomfortable with? We know that risky sexual behaviors lead to potential pregnancy and sexually transmitted infections. So additional questions that we may ask will be, what kind of activities do you like to do? What are some ways you can improve your diet and decrease calories? We know that we have to talk about injury prevention. We have to talk with them about texting and driving. Talking on the phone, remember, decreases their response time and it diverts their attention. We need to talk to them about seatbelt use. The CDC reports teens have the lowest seatbelt use of any age group, and approximately 58% of teen drivers that were killed in crashes were not wearing their seatbelts. We also have to talk with them about drinking and substance abuse. We know that it decreases inhibitions and it makes them more vulnerable to problems. We should remind them that they should never go off and leave open food or drinks and then come back and drink them, especially if they're at a party, because you never know what somebody's put into them. We can tell them that group activities may be safer for them because, remember, there is power and safety in numbers. And we can remind them that it's okay to say no if you're not ready to have sex. And we need to talk to them and get them to brainstorm. If somebody's trying to pressure you, what would you do? We can present scenarios to them. What would you do? And help the adolescent talk through them. We also need to praise them for their conclusions if they're positive, and we can give them other recommendations if they're needed. We should also remind them that the internet is not always safe. There are predators that may pose as something that they're not. And the adolescent should never divulge their location or any personal information to strangers. But we should always thank them, too, for coming into the clinic and considering contraception. So I've given you some slides that talk about bullying. We're not going to have time to go over that, but I wanted you to have this information. Bullying is very hard for some clinicians to identify, but if for any reason that you suspect that there's some bullying going on, then the main thing is we really want to encourage our teenagers, our adolescents, to talk to a trusted parent or counselor or coach or religious leader, some trustworthy adult, because they can always help brainstorm ways to deal with the problem or the situation. And we put these tips in your handouts. Adolescence is a period of significant cognitive and psychosocial growth and development. It's a time of relative good health. Most morbidity and mortality in this age group is the result of risky behaviors, risky high-risk behaviors. This may include drinking and driving, multiple sex partners, poor impulse control. Think about spring break and the pictures you've seen on the television. You may ask, as a clinician, how do we address all of this information with our patients? Because there's only a minute amount of time that we have to spend with them. Well, what we're going to do is we're going to tailor this information to our patients. We need to size up what's going on with them. As we're assessing and asking questions, we need to expand on the particulars that are noted, especially in the history and assessment. We address those specifics if your review tells you to go in that direction. Providing effective medical care to adolescents requires understanding, again, of their psychosocial and developmental stages. When clinicians talk with adolescents, they may see them as very self-absorbed, and they're consumed again with their appearance and what's going on within themselves. They may laugh and giggle when you talk to them, and they may be somewhat disrespectful. Adolescents may put up a good front, and they may act like they know it all, or they may act shy and timid, and they may constantly change their minds. And we see that a lot as they come in for their methods every 3 months. It seems like that they're changing from one method to another. We know that adolescents have poor impulse control. Everything seems really intense with them. Clinicians may find it difficult to get information from adolescents. And the clinician should have a lot of tricks in their bags, a lot of strategies to help them pull out all that needed information to get from the adolescent patient. So let's talk about how the adolescent feels when they come in and are talking to the provider. The adolescent may feel like they're being judged. They feel like that we're disrespectful of her decision, and they feel like we may minimize the seriousness of her life. The clinician needs to be innovative to engage the adolescent. We need to be attentive to the issues. Our radar ears should go up. What if the adolescent tells you that she's not sexually active and her tests come back positive for chlamydia? Were there any clues? Did we miss those clues? We really have to hone in. We have to hone in and have good observation skills and good listening skills and good questioning skills. The adolescent may feel like that we really don't understand them. They feel like that we have a natural alignment with their patient and that there's a big divide between our worlds. The major task that adolescents have is how to deal with and come to terms with their new body image. They have a big growth spurt during early adolescence and they feel awkward. But we have to keep in mind approximately 3 to 4% of adolescents have had sex by the time they're 13. Many engage in exploratory sexual activities, especially with the same sex. A major threat in this age group is that they are very impressionable and they may try things that are not safe. Again, our radar ears should go up and we should give them whatever guidance we can as their clinician to help them to stay safe. We need to engage the adolescent, and I reiterate, we're going to tailor our care to that specific patient. What are the boundaries? The adolescent is trying to figure it out. If they're uncomfortable with one level of intimacy, then they're usually going to go back to a setting of intimacy with their partner where they feel a little bit more comfortable. We may give some guidelines to the adolescent for the type of partner that they most likely would like to be with versus a partner who might belittle them or tear them down. We want to ask them the question, would you rather be with someone who's kind and has compassion? If they really care about you, what would you do if something serious happened? Versus somebody who wants to belittle you or tear you down. Remind the adolescent that their job is really to find their lifetime partner, one who really cares about them and who they'd like to spend the rest of their life with. We want to give the adolescent guidance to forming healthy sexual behaviors. We want to dispel any myths or misconceptions that they may have about sexuality and especially about contraceptive methods. For example, if you hear an adolescent say, well, I heard IUDs can cause you to be sterile, we want to clarify that information. We want to give them evidence-based and factual information. And this is Mrs. Jitters. She is a new addition to our family, one of my grandson's cats. We're going to talk about an early adolescent. Her name is Gemma. Gemma is 13 years old, and she's in the 8th grade at Hollis Middle School. Her mother found her phone and saw where Gemma had texted naked pictures of herself to her boyfriend. And of course, Gemma's mother freaked out. She brings Gemma into the health clinic, and she's adamant that Gemma be placed on birth control. Now, we have to keep in mind that Gemma's 13 and she's not an emancipated person. And the parent has a right to be present with Gemma according to state law. The provider needs to maintain an alliance with Gemma's mother, but if possible, we need to get her to wait outside at some point during the exam so that we can have a little private time with Gemma. We're going to talk with Gemma. You may have to lead the conversation somewhat. A lot of girls at this age don't know what to say. They may giggle at everything that's said, or they may be really shy, or they may say, I don't know. And that's a very common response for them. So we try to use open-ended questions, but we can make a general statement before the question. One nurse practitioner in Model Clinic recently said this, and it seemed like it was really a good way to put this. She was speaking to a patient and she said, "We see a lot of patients that are about your age who come in with sexually transmitted infections, so we recommend a condom always be used if you have sex so that you can protect yourself against sexually transmitted infections." So we could ask the question, "Gemma, what's the best way to protect yourself from a sexually transmitted infection?" We have to acknowledge to the adolescent that things are changing for her. Her body's gone through a growth spurt, she's developing breast, and she's feeling differently about herself. She's feeling differently about a lot of things. At this time, it's a really good time to try to reel them in, as I said before. Look them eyeball to eyeball and ask rhetorical questions as you're trying to get the information that you desire. You look at them and you say, "What is sex?" Ask them if they've had sex, and ask them, "What do you think I mean by that?" We're trying to build rapport for the future. We praise her when she's coming into the clinic. Tell her that it shows maturity and that she's wanting to take care of herself. Tell her it's a good time to think about birth control before you need it. It's time to explain to the adolescent about birth control methods and how they work. We're going to brainstorm with her what's the best method for her that she's going to be most compliant with. Help her make an informed, good choice, but tell her that if she doesn't like it, that she can always come back in and we might try something else that she would like better. By the way, Gemma chose to use Depo, and she's thinking about Nexplanon on her next visit. The most important skill in caring for the adolescent is establishing rapport. We have to speak directly to the adolescent. We ask them, "What brings you here in today?" And we ask permission to give out information if someone's with them. We talk directly to them. Indicate that we have some questions that we have to ask them to complete their assessment, and the questions are routine, but they're very personal. And we do have to ask that adolescent to speak freely in front of a parent or guardian, or we ask them if they'd rather mom or whomever is with them to step outside for a few minutes. We want to obtain some private time with the patient. It's very important because the parent or guardian may not know the extent of the adolescent's sexuality. We can say to her, "Mom, we appreciate you bringing in your daughter, but we need to do her exam, so if you'll wait in the waiting room or in a seat outside the door, then we're going to call you back as soon as we finish the exam." This also is a time that it allows empowerment of the adolescent's responsibility for their own health, and it helps develop that relationship between the clinician and the adolescent. And it's a perfect opportunity for the clinician to obtain better sexual history and remind the patient during that time that you're maintaining her privacy and that you're not going to divulge any information without her permission. This provides the opportunity, again, as I said, to obtain a better history, and that I just said that, so I'm going to go on to the next slide. We're going to dialogue with the patient. I'm going to ask you a few questions about your sexual health and sexual practices, and again, we've mentioned that about these being very personal questions, but good for your overall health. I'm going to kind of skip through this slide as well. We want to talk about the 5 P's of sexual health as we're discussing things with the patient. Remember, we're trying to tailor all this information to our patient, and especially in the appropriate patient situation or circumstances. We're going to talk about their partners, their sexual practices, protection from STIs, past history of STIs, and pregnancy prevention. As we're talking about their partners, we need to know the number and the gender. We should never assume that. If they've only had one partner over the past 12 months, ask about how long they've been with that partner, and ask about the partner's risk factors, such as drug use. If they've had more than one partner over the last 12 months, then we're going to have to explore specific risks, such as condom use and, again, partner's risk factors. So we can have this dialogue, and one of the dialogues will be, have you ever had sex? And then we need to ask, this includes having sex more than just in the vagina. We ask them how many sex partners they've had over the last 6 months and what's the total sexual partners they've had in their lifetime. And we ask, have you had sex with men, women, or both? As we dialogue with the patient, we have to be more explicit about the kind of sex that they've had. And this tells us whether or not they're more at risk for an STI. We also have to ask the questions, what kind of sexual contact do you have or have you had? Genital, with the penis in the vagina, anal, the penis in the anus, or oral, the mouth on the penis, vagina, or anus. This guides the patient's risk, their risk reduction strategies, and the need for more testing, the anatomical area from where we're going to obtain our STI specimens. Based on the patient's answers, it helps us to discern which direction to take our dialogue. Remember that we're going to individualize for each patient. If a patient has had a monogamous relationship over the last 12 months, then our risk reduction counseling may not have to be included. Depending on the situation, the clinician may need to explore abstinence, monogamy, condom use, patient's perception of their risk, and STI testing. We ask, do you or your partner use condoms? And we emphasize that they should use protection every time. We always ask them if they've had any questions about protection from STIs or any other questions that they'd like to discuss today. We also dialogue with them if they've ever been diagnosed with an STD or have you had infections more than once. The past history of STIs may put our patient at increased risk now. How your patient responds to you helps you know how to get more in depth with the questions that you ask. All of these slides are in your handout, so if I'm going kind of fast, just you can review these in your handouts. Based on the previously obtained information that we've gotten from our patients, we can ask the patient we know whether the patient is at risk of becoming pregnant. We have to ask them if they want a pregnancy and is this pregnancy desired. We can also ask them if they're concerned about getting pregnant. We tailor this for each patient. We ask these questions if they're not on a method. If they're on a method, there's no need to go there. If we're addressing a male patient, we ask them if they want to father a child, and we ask them if they're concerned about their partner getting pregnant. We complete our history dialogue with questions that were not previously answered, and again, we're going to tailor this to our patient. We thank the patient for being open and honest with us, and we praise her for her use of protective practices. If the patient's at risk for STIs, we encourage her to get testing, to practice prevention strategies, and this includes abstinence, monogamy, and consistent and correct condom use. We address any other concerns that this patient will have. So let's talk about the middle adolescents. Middle adolescent is the age between 15 and 17 years. Approximately 70% of these patients will have had sexual intercourse, and sexual experimentation is normal in this age group, and this is according to the CDC guidelines. The major developmental task in this age group of middle adolescent is developing a personal identity. Do they want to be a diva or do they want to be a bad girl? And they're going to be experimenting with their roles. One of the major threats to their role experimentation is that they are trying to gauge, of course, the responses from others, and they're weighing the responses, the merits of those responses as they develop their identity. If they're trying to be a bad girl, we know that they're more likely to use risky behaviors such as starting to smoke, use of drugs or alcohol, and be promiscuous. Middle adolescent is a time where they begin to have an understanding of extremism. They're understanding the difference between having sex one time with 5 guys is not the same as having sex 5 times with 1 guy. This is a time of experimental role experimentation. They're trying to figure out if they want to be a mom with 3 children or whether or not they want to be a doctor or a lawyer. What do they want to be, or who do they want to be like when they're full grown? It's a good time for us to educate the adolescent in clinic and to clarify information for them, because oftentimes they're getting their information from other sources and they may not always be correct. They get information from their peers, from Facebook, or somewhere on the internet, and they're generally relying on their friends to help them make decisions. This is also a new addition to our family, Brownie. I want to talk about a middle adolescent person. Her name is Maria. Maria comes into the clinic today for a checkup. Her parents don't know that she's here, and she's had sex since she was 14. She's had 6 partners, mostly 3 to 4 years older than she is. Now, there's several issues going on with Maria that we see. She's had multiple partners. She's had older partners. So we want to explore sexual coercion with Maria. At this point in time, middle adolescents begin to imagine the consequences of their action, but they might not fully understand them. It's a good time to give them education on methods. We need to focus on how this is going to work for them. We've got to help them envision and embrace the method. Middle adolescents are concrete thinkers, so we may have to show them. This is where PT plus 3 box, I think, comes in. They're concrete thinkers. We have to show them what an IUD looks like. We have to show them what a pill pack looks like. We also need to understand the intense influence of their peers, because they are getting information from their peers, and they may come in wanting a method that their friend has because their friend likes it. We also have to remember as far as public health goes, that we do have reporting guidelines, and you can refer to that in your clinic protocol manual in the family planning section on page 39 to 41. Maria uses condoms intermittently, but she doesn't necessarily want to be pregnant. She broke up with her boyfriend 2 days ago, but she really doesn't see any reason to discuss contraception. But we have to remember that Maria is high risk for pregnancy. We ask her how she would feel if she were pregnant. We've got to sell the right method of contraception for her. We've got to convince her that she needs birth control. And we have to make sure that she knows about consistent use. It's not uncommon for adolescents to practice exploratory same-sex activities. We know that societal trends have changed in the last decades, and as clinicians, we need to be comfortable talking about sexuality. We also have to be very sensitive and aware when we're talking with patients. It's very important while we're doing our interviewing. Remember that experimentation by these adolescents may lead to substance abuse, academic difficulties, depression, and even suicide. As we're asking these questions, we need to ask the adolescent if they feel safe in their home. Do they feel sad? do they have problems with depression, or if they've ever had thoughts of harming themselves. We also ask them if anyone has ever forced them to have sex, or anybody ever force them to do something that they're uncomfortable with. We also need to make sure that our adolescents are using condoms. Lack of condom use in teens is mostly because she feels like he's going to take care of her. We know that the capacity to trust is crucial in forming relationships, and it's good for forming healthy families, and teens really want to trust their partners, but they don't use condoms. So as healthcare providers, we've got to relate to the adolescent that condom use is not about trust, but it's all about health. By the way, Maria chose to use an Nexplanon. We're going to talk about late adolescence, age 18 to 24. Approximately 70 to 90% of adolescents at this point in time will have had sexual intercourse. They're less concerned about their bodies and identities. They have a diminished but not resolved need for risky, provocative experimentation. Their major developmental task is planning for the future. And their major threat is that sometimes they have these idealized expectations and they're equating emotional health with physical safety. We have to, they believe because I love him, he's not going to hurt me. So we have to get them to understand they still have to protect themselves. I just took this picture this past week, so I wanted y'all to see that. We're going to talk about Summer. This is a case study about Summer, who's 21 years old. She lives with her boyfriend of 8 months. Both are seniors at the State University. Summer uses birth control pills, but sometimes she misses 3 or 4 a month. Summer came into the clinic to be checked for a sexually transmitted infection because she had a hookup. While she's there, Summer asked about birth control that's easier to remember. So, what would you recommend to Summer? Would you recommend the ring or the patch? Would you recommend that she change to a different pill? Would you recommend Depo or Nexplanon and not an IUD? Or would you recommend Depo and Nexplanon or an IUD? Or would you recommend just condom use alone because she's going to get a sexually transmitted infection? I hope that all of you recommended option number 4, but we also need to include for Summer that she should use a condom and make her partner use it all the time. Recent information in a study shows that if the adolescent got a prescription for monthly use, they tended not to be very compliant with their pill use. And at the end of 12 months, only 33% continued with their pills because it was much harder to go and get those pills from the pharmacy. So if they were given more pill packs, then they were more compliant for a longer period of time. Per our protocol, when a person comes in initially, we give them 3 packs. But if they're an established user, we need to give them as many as we can, up to a year's supply. Late adolescence is more able to develop intimate relationships. They have more mature skills, and they have a better understanding of the consequences of risk and the risk that they have with STIs. As a clinician, we should give them a positive approach and sell contraception to them. Remember that LARCs are best, and we always need to encourage the consistent use of their contraception. Other factors that may influence women's health, of course, is obesity. We know that the body mass index predicts future disease. If they're overweight or obese, they're having more risk factors for diabetes, hyperlipidemia, hypertension, and various cancers. We also know that eating disorders are often associated with other mental health disorders, including depression. And most of you are familiar with these, anorexia and bulimia, and I'm not going to go into those, but we also know that these eating disorders can be related to self-esteem issues. The physical exam is not required to obtain contraception. I can't stress that enough. We're going to be doing urine cultures when they come in, as we do a pregnancy test as well, but we need to make sure that they're getting a method of contraception before they leave the clinic. Per our protocol, we obtain a medical history and a blood pressure, but again, the physical exam is not required. I'm not going to go over the immunization for adolescents. We just need to make sure that our immunizations are caught up if they need to be. But one thing that we do need to emphasize for our young patients is the HPV vaccine or the Gardasil or Cervarix. It's best initiated at age 9, and the second dose is 1 to 2 months later, and the third dose 6 months after the first dose. We want to be sure that we tell them a little bit about HPV. The human papillomavirus is the most common sexually transmitted infection in the United States. An estimated 14 million persons are newly infected every year. There may be no symptoms whatsoever with this, and the low-risk strains are usually self-limiting. But we do have some high-risk strains, which includes types 16 and 18, and those can cause cancer. And the high-risk strains are the ones that are the most common cause of cervical cancer in the United States. Both boys and girls are now recommended to get the HPV vaccines.
Hello. This is one of Deborah's roses that she grows at home. I'm Beth Allen, and hello to everybody. I hope everybody's doing well. We're going to jump off here and go into young women, ages 19 to 39, defined by ACOG. During these years represents the most visits in women's health. These are the reproductive years and years where we need to stress best health. Of course, a huge part of this is contraception and pregnancy with best health, and then cervical screening is started in these ages. You can't talk about contraception in the young woman without interconnecting hormonal birth control and the menstrual cycle. With that, we have to develop some questions that we discuss with the patient about their menstrual cycle. What is their pattern? How often are they having cycles? Is it once a month, twice a month, quarterly, less than that? Then that will evolve into what type of problems that may be with that patient as far as what type of options we can give them for birth control. With this type of information, we can develop with them a reproductive health care plan during these years. Okay, so we're going to go to an overhead here, and we're going to start this by talking about the menstrual cycle. The menstrual cycle is like an orchestra, and the orchestra has to work together, all together, to be in concert. So the key players in our orchestra are the hypothalamus, the anterior pituitary, the ovaries, and the uterine lining. The hypothalamus releases gonadotropin hormone. With this release, it stimulates the anterior pituitary to produce follicle-stimulating hormone and luteinizing hormone we call FSH and LH. With this, the process starts follicular development, ovarian development, ovulation, and the corpus luteum formation. This is known as the proliferative phase in the first or the beginning cycle, or the first half of our cycle, you could say. So then the FSH acts on the ovaries to produce estrogen and progesterones. During the beginning of our cycle, and you see in this proliferative phase, you see this steady rise of estrogen that happens here. Let's adjust that, yeah. Steady rise of estrogen that happens here. Without this steady rise of estrogen during this initial part of our cycle, or the first half, we will not have this LH surge. This is crucial to the pre-ovulatory and ovulation. So without this rise in estrogen, we won't have ovulation at all. Okay? So then, after the LH surge, ovulation occurs and we go into the secretory or luteal phase. At that time, more progestin is produced and rises. This causes the endometrium, as we know, to get thick and build up and lush, full of nutrients for implantation. Of course, if implantation doesn't happen, then, fertilization doesn't happen, then menstruation begins again. We have to have sort of a basic understanding of this cycle to know how to use birth control and the effects of birth control. And Dr. Thomas, would you like to add just for a moment any comments about that with hormonal contraception in the cycle?
Surely. Thank you and good morning. Beth, thank you for that excellent basic sciences overview. I think one very important point, we talk all the time during our consult sessions, and I think the important thing here is to try to link back. I'm always asking you questions. So when was the last period? And what was her menstrual pattern like over the last 6 months? And I think what that basic science overview sort of emphasizes is that there are several players involved here. And as Beth mentioned, everybody's got to be in concert to have that effect that we're looking for. So it's not many of the patients that we see that that may have secondary amenorrhea. The likelihood is that we see a triad that reminds us that maybe they're PCOS clinically. So we're thinking that we've got a patient who is overweight, somebody who is showing the stigmata of hyperandrogenism like acne or in facial hair, and then they've got irregular cycles or anovulation. But as you can see from Beth's demonstration, there could be a hypothalamic issue, where the patient has hypothalamic amenorrhea. There could be PCOS, as I mentioned, and all the stigmata associated with PCOS. There could be something happening at the level of the anterior pituitary, such as hyperprolactinemia, and the list goes on. You can have premature ovarian failure. So these are all things that you have to sort of be thinking about. So it's hence the reason for all the details, and as Dr. Miller always says, the devil is in the details. You've got to ask the questions about that, about the menstrual history. And Beth mentioned, the major players, but there's a lot that's happening during that cycle. There's stimulatory and inhibitory events that are going on. There are other hormones that are being produced, inhibin A and B and peptides, and there's really truly, and I think that the term she used, a concert, there is really truly a concerted effort of positive and negative feedback that's going on to bring this kind of delicate process that is very unique. When you look at endocrine systems throughout the human body, that LH surge is truly unique to the menstrual cycle. So I think this is really a great segue to talk about how combined or hormonal contraception plays a role in how that affects all of these players. So I'm going to turn it back over to Beth.
Thank you so much, Dr. Thomas. Nobody can explain things to us like Dr. Thomas, right? So, no pun intended, but we are a well-orchestrated menstrual cycle as women, right? We're multitaskers, to say the least. So let's move on. So why menstrual cycle 101? Well, we need to understand that basic premise to understand the way contraceptives or hormonal contraceptives work in that process. Hormonal contraceptives work in that process by inhibiting or suppressing that LH and that ovulation. So it's a negative feedback, as you can see on this slide, mechanism. And in essence, it suppresses ovulation, it keeps the endometrial lining thin, and it makes the mucus more viscous or harder for the sperm to traverse. And that's the basic mechanism behind hormonal contraception. What we should also know in that is that progestin is our main contraception in the combined oral pills. So the progestin are in combined hormonal contraception. So the progestin acts as the main source of the contraception. Estrogen keeps stability to the uterine lining and allows for less bleeding and controlled cycles that they like on combined contraceptives, as we see. So when we look at giving methods and how we want to issue methods, we need to look at it in sort of a top-tiered approach. And CDC recommends this top-tiered approach, and contraceptive technology, many sources now recommend this top-tiered approach because we've seen great benefits from the use of LARCs. We have to remember we have to tailor this or fit this to our individual patient needs. So we have to use guidance through the medical eligibility criteria. In about 1966, half of all pregnancies were unintended. It is the same now. Einstein's definition of insanity is doing the same thing over and over again and expecting different results. So we've got to change things a little bit in our approach. Effectiveness of family planning methods are described here in this top-tiered CDC diagram that you have in your handouts. The rows represents the tiers with going from the highest level of effectiveness down to the lowest level of effectiveness. Many sources teach this and want us to teach this in a top-tiered fashion so that patients understand where their percentages lie as far as the birth control method they've chosen. You know, so for example, if they've chosen the implant or the IUD, those are the highest level of contraception on that tier bracketing, and they have less than a 1% chance of getting pregnant on those. So when it's important for birth control, it's important for them to know their percentages of the methods they choose. This makes it easy for us. We can use this type of approach, and it sort of gives the patient the information without us having to say a whole lot. So in looking at LARCs and how this all came about, studies were done, and right now we want to go to a video clip that shows some results dealing with teenagers and the use of LARCs.
This is Jeffrey Drazen for the New England Journal of Medicine. You're the chaperone at a high school Halloween party. Sometime into the night, a 17-year-old girl lifts her mask and grabs you by the arm. You recognize her as a longtime patient of yours. "You've got to help me," she says. She tells you about the heart palpitations, the drenching sweat, and the crippling feelings of nervousness. It all started when a boy at the party revealed how much he liked her, and she feels that things could get serious. She's terrified of the possibility of becoming pregnant, however, and says she needs advice. The girl tells you that a trip to the pharmacy went nowhere because she had no prescription, no money, and just no idea what her options are. "All I know is I don't want to get pregnant," she tells you. How can you help her? As teens in the U.S. have become more sexually active, the high rates of unintended teen pregnancy have become a public health concern. Each year, more than 600,000 teens in the United States become pregnant. If we could eliminate some of the barriers to teens having access to contraception, would pregnancy rates fall? In a study from St. Louis, the authors removed financial and access barriers to contraception. The study involved 1,400 adolescent girls aged 14 to 19 who were sexually active with a male partner or were planning to be sexually active with a male partner during the next 6 months. The teens were counseled on commonly used contraceptive methods with an emphasis on the benefits of long-acting reversible contraceptives, which include intrauterine devices and implants. In the study, participants chose a method and were provided with it at no cost. Most chose an intrauterine device or an implant. They then were followed for 2 to 3 years. The The results were compared with the pregnancy, birth, and induced abortion rates observed nationally among U.S. teens from 2009 to 2010. The national rate of pregnancy among sexually active teens was 158 per thousand, while in the study the rate was 34, or one-fifth the national rate. Rates of birth and abortion among the study participants were substantially lower as well. The study supports a strategy of educating teenage girls about birth control, and in particular the effectiveness of long-acting reversible contraceptives and providing them free of charge. At the party, you tell the girl you definitely can help her and suggest she schedule an appointment with you. She calms down and, feeling happy and assured, goes back to enjoy the party.
Okay, so that's a great way. It says it a lot better than I can say it. We see this presentation often in our clinics. We also get stopped at the local Dollar General about these types of questions. But this is a good way to show you how this study improved unwanted teen pregnancy rates to about 1/5 of the national teen pregnancy rate, and just proves the use of LARCs, and that if it's easy for them to get their methods, how effective this can be. As it said in the video, greater than 600,000 teens 15 to 19 become pregnant each year. So we want to help improve these numbers through the Alabama Department of Public Health. I just would like to take a minute to let Dr. Thomas summarize some of this for us.
Thanks, Beth. We're going to take a break shortly, and I think that this is probably a good point or a good segue for Beth after the break. That she's going to introduce one of a chart that's sort of similar, I guess, to the CDC chart that ADPH is going to be premiering. And I always feel as if, especially in dealing with our adolescent population, that visual aids are always really helpful in this age group. And I think when they see that their methods are tiered according to efficacy, it will certainly help. So we'll see what ADPH is going to debut in that regard that is going to be helpful with our patients going forward. I thank these guys for an excellent overview of the adolescent patient and the other different age group of patients that we deal with. Particularly, I think the biggest change for us is the decoupling of the pelvic exam to contraceptive use. And I think that's something that, with everything else, it's a paradigm shift for us. And as Deborah has reiterated multiple times, that the two are not intrinsically linked. So if your patient for some reason is unable, you're unable for some reason, whatever that reason is, to perform a pelvic exam on your patient, that does not mean your patient should leave the health department without birth control. So I wanted to emphasize that point. The other point I think that Deborah mentioned that is equally important, I know she went through a lot of scenarios and questions, and it's like I've got enough to do already without asking all of these details. But I think she mentioned that she talked about sizing up your patient. So I just want to remind you guys that you've got to size your patients up and tailor whatever you do according to the patient. So you don't have a spiel, the same spiel for every patient that you see. It's important, especially in dealing with the adolescent patients, because as she mentioned, we want to reel those patients in. My last point surrounds our HPV vaccination program and the fact that overall here in the United States, we've got a really low uptake of HPV. It's less than 50%. And we have got to do better. And you can imagine who's leading, in terms of low uptake. It's the Southeast, and we're part of that group, and for a number of reasons. I mean, there are sociocultural issues surrounding that, but I urge you to seize the opportunity to talk to your patients about HPV vaccination. The sooner they vaccinate, the better. Before the sexual debut is ideal, but we encourage catch-up vaccination. School is still out in terms of how effective the catch-up vaccine is, meaning that you didn't get the patient initially or earlier, at that particular age that the CDC or the ACIP folks are recommending for vaccination. So go on ahead and talk to your patients about this. This is right up our alley. It's important for us to discuss and talk with our patients and make sure that they're vaccinated. We've got to do a better job as public health advocates in that regard. Thank you.
Okay, well, we'll go on to our break. We'll be back in about 10 minutes. Welcome back. Before we get started, I did want to take this opportunity to introduce someone so that you could put a face with a name. Tina Pippin is our new Laurie Stout, our nurse manager here in Family Health Services. So I just wanted to take this opportunity to say welcome and so that everyone would have a chance to see you. And we're glad to have you.
Thank you.
Thank you. Okay, Beth?
All right, want to go right now on into our methods discussion, continuing with top tier methods, and go to our overhead. As CDC outlined, our tiered method system, the Alabama Department of Public Health is unfolding a new pamphlet that has this tiered system laid out for us. Some of the main points that Title 10 and Dr. Thomas wants us to sort of relay about this is that it is a pamphlet. We should give this to every patient. It lists the tiered steps of the most effective to least effective. We don't have to explain every method on this page every time a patient comes in. If a patient is happy on their current birth control method, we can just simply tell them we're giving them a pamphlet on different options if they choose to want to talk to us about that. It will soon come out to the health departments, not quite ready to go out just yet. Okay, just going to go on to the slides and talk about our national evidence-based guidelines. ACOG and the United States Medical Eligibility Criteria are guidelines that help us to choose the safest and most effective type of birth control for our patients. Just wanted for those who weren't familiar for the way that the USMEC looks to show an overhead on this just real quickly of an appendix that we have of the United States Medical Eligibility Criteria. Basically, there's 4 categories in this. And in Category 1, there's no restrictions for any methods. And in Category 2, the advantages outweighs the risk. And in Category 3, the risk outweighs the advantages. And in Category 4, this is an unacceptable health risk to use this method. So these are guidelines. I just want everybody to sort of see the format. We have the wheels that we also use that has the USMEC criteria on there. And along with this is going to be an attachment of the way this looks in your handouts so that you can review this a little bit closer. And again, you know, just to stress, it's not a one-size-fits-all with birth control. And, you know, where this is concerned, these are guidelines to give us the best and safest birth control methods for any patient with coexisting medical problems. So I just talked about that slide. I'm going to go on forward. In this, decision tree, if you will, we want to always have sort of a silent voice in our head saying, do no harm, and to be safe, and to give the most efficacious and, safest methods that we can for our patient. Before I jump into methods, I just want to sort of bring home this point and talk about a case that we had this week in model clinic. We had a 34-year-old who came in. She had a BMI of 54. A few years ago, she had a pregnancy, and after delivery, her physician put her on COCs. 1 month after being placed on COCs, she had a pulmonary embolism. So when we say it's not a one-size-fits-all, it's just to really bring home the point that we really have to have safe practice. We have to tailor, like you've heard us say throughout this. We can't issue COCs in somebody with this type of risk factor. It's not safe for them. It's not to belabor this point, but it's just so that everybody understands that there's consequences to poor choices, and then there's consequences to good choices. So we want the good choices in Alabama Department of Public Health. Where methods are concerned, I'm not going to try to go through every, we're going to do this in a tiered fashion, and I'm not going to try to go through every risk and every contraindication. We have a great reference in our Alabama Department of Public Health protocol, so I'm just going to refer you back to that, and we're just going to try to go through these methods and sort of hit the high points. Okay? So intrauterine devices. Intrauterine devices in the U.S. Are a T-shaped type device. There's 3 basic types. We have the copper 10-year, the levonorgestrel or the Mirena 5-year, and the levonorgestrel, the Scala, the 3-year is our newest one. So just wanted to bring that one out. It is being used in Alabama, and we're hearing about these. As far as just benefits and drawbacks, overall these are all in the top tier. So they have the highest effectiveness, less than 1% unintended pregnancy rate with these methods. With the Paragard, because it is non-hormonal, it is great for patients who can't use hormonal contraception. I guess the downside to it is we hear our patients complain of bleeding more with this, and there is possibility of irregular bleeding and cramping and those sorts of things. With the Mirena and the Scala, they do contain progestin, levonorgestrel, so the bleeding is more controlled, and it's effective even for PMS and dysmenorrhea and symptoms that go along with that. It is even indicated for women with abnormal uterine bleeding. So it's a good birth control method for those type patients who can't use estrogen-containing methods as well. Some of the drawbacks that we see are patients come in and the string is not visible when we do the speculum exam. And so one point for everybody to know is that you must send a patient for an ultrasound to confirm whether or not there's proper placement of the IUD. And in the meanwhile, they need a backup method. I think most of us know this, but just for our newer folks, wanted to make sure we made got this point across to everybody. The main thing with this T-shaped device, as far as major drawbacks, is it can have perforation, of course, and expulsion. And so, you want to just lay those possibilities out as you're talking to the patient who you can't actually see the string visible. Okay, so new on the IUD market is intrauterine ball. This is a copper-releasing spherical device. It's actually under study and not offered in the United States at this time. They're comparing the efficacy against the T-shaped classic IUD device. This device is advertised, if you will, to have less perforation, less pain with insertion. It coils, and so it's supposed to be an easier insertion. These are all the promotions of it as it's being discussed. I just wanted to show this slide because it sort of shows you how with insertion that this actually coils out and fits to the uterine lining there, okay, or the uterus. Okay, let's go on to a case study. Here we have a 40-year-old, Gravida 1, Para 1, family planning initial for exam, desiring to start Depo as her birth control method. Advised by her oncologist to get back on hormonal birth control. Her vitals are normal with a BMI of 22. She is a 1/2 to 1 pack per day smoker. She reports history of breast cancer in 2008 with lumpectomy, lymph node dissection, chemo, and radiation treatment. She reports remission for 6 years and was taken off tamoxifen in May 2014. She is under care of an oncologist yearly. Her mammograms are up to date and her physical exam is negative today. Is Depo okay, and what should we outline with this patient as a teachable moment? Whoops, let me go back. Okay, so as a teachable moment here, she is not a candidate for hormonal birth control methods, simply put, because of her history of breast cancer. One of the best methods, well, if you said barrier, that would be okay, but if you look at this from a top-tiered, approach, one of the best methods for her would be the copper IUD, and then of course, barrier if she did not want that or sterilization. Okay, let's move on to the implant. It's a single rod implant. We're all very familiar with this by now. The benefits is it's long-acting. It is in the top tier, so there's less than 1% unintended pregnancy with this rate. It is etonogestrel releasing for 3 years. We've put in many, and I'm going to give y'all some numbers on that in just a second. Some of the drawbacks that we see most commonly are irregular menstrual bleeding or irregular breakthrough bleeding, we call it, and headaches. So those are sort of the most common types of side effects we see. Just for note, the literature says that it's not ideal for women greater than 120% of their ideal body weight. However, we know that we have patients that fit this category, that progestin only is a good method for them. We have patients that we've used this in, and we've had success with this. But we do just need to, have a counseling point there with our patients for backup method counseling. Okay. So some statistics on that. We started Implanons at the time, the first implant, in May of 2008. And up to date, through August of 2014, as a state agency, we have put in 7,036 implants. I think that's a pretty impressive number, and I wanted y'all to hear that number. So again, that's 7,036 implants. Okay, let's move on to another case study. 18-year-old Samantha, Gravida 0, last menstrual period about a week ago, presents for a family planning annual on Depo for 3 years and current. She's extremely excited about moving out of state for college. She tells you that she had a physical with her local doctor, her PMD, and recently was told she had elevated LDL and decreased HDL, chronic sinusitis. She is exercising now daily and using Medrol dose packs for the sinusitis intermittent 2 to 3 times a month. No other meds at this time. She will leave in 3 months and not return for at least a year. Her physical exam today is unremarkable. Vitals are normal and BMI is 26. What is Samantha's best top-tier approach for birth control? So one point about this 18-year-old, and I'm just going to back up so you can see the age again, and nulliparous, is that IUDs are certainly not contraindicated in this age group without pregnancy. So IUD as a top-tier method and implant would be an ideal choice for her and the best choice with a college student leaving out of state. Depo is fine, but Depo would not be a choice if she fell into any long-term or chronic steroid use, just for point of reference on that. Okay, got another case study. We love these case studies. 32-year-old, gravida 1, para 1, blood pressure normal, BMI 21, last menstrual period was a month ago. She is in for her family planning annual. She's having bleeding and painful periods, desiring hormonal birth control, and she is currently taking simvastatin and aspirin daily. Current method is condoms. Recent history of stroke ×2 within the last 4 months. She was hospitalized at that time and has no follow-up, no current doctor, and has residual left-sided numbness and tingling. This patient has had drug abuse for 20 years and currently uses IV morphine 2 to 3 times a week. She has headaches 2 to 3 times a week from a motor vehicle accident that she sustained in 2004 with a head injury and crushed ankle. Smokes about half a pack per day. She is bipolar and not under care for that and is not taking any meds for that. She has no suicidal ideations today. During the physical exam, you note that she is sluggish and unfocused. There is BV on wet prep. She did rule out for 2 weeks on her pregnancy test, and it's negative today. What is the best method for this patient? Clearly here, we don't need an unintended pregnancy with the risk factors that have been laid out for this patient. Just a note of reference, this is an actual Alabama Department of Public Health patient, and just to show you the complexity of what you all deal with day in and day out, this is an actual case that we had. Phone consult is definitely warranted in this case, and because of the risk, benefit as far as pregnancy with this patient, Dr. Thomas with consult approved for Depo one time, and then the patient was set up for an IUD, which this patient on an ongoing basis wouldn't be able to use Depo. So that sort of reflects back to our USMEC, because they categorize this as a category 3, which means the risk outweighs the benefits for this patient. Okay. Bilateral tubal sterilization is in the top tier method, of course, and I'm not going to read this to you, but it is highly effective. It's a generalized outpatient procedure, and as far as drawbacks go, once patients come off hormonal birth control, we hear them complain a little bit more with their periods, but that seems to settle down with time. Just some points of matter as far as coverage. Title 10 does cover this, Plan First, and Medicaid eligible patients. Another form of sterilization is transcervical sterilization called Essure. This is a transvaginal hysteroscopic procedure where a thin or small stent-like device is placed in each fallopian tube. It takes about 3 months for the scar tissue to form around that tube so that complete blockage of the fallopian tube occurs. So during that time, the patient has to use another method, and then the patient has to come back in 3 months to the doctor for follow-up x-ray on that to be sure that the occlusion has happened on both sides. So for that reason, we don't see that this procedure has really taken off maybe as much as we first thought it would, because there's some drawbacks in that the patient can't immediately rely on it, and then they have to follow back up. And we've even seen patients in our health department thereafter, that didn't follow up with their doctor on this procedure. As far as the benefits, it is permanent, and it's less expensive than the bilateral tubal ligation, and it is an in-office procedure. Sometimes the drawbacks include that it really can't be placed for various reasons, And as far as tailoring this to the type of patients that we might see, just think about your high-risk patients that I just described earlier, the patient that we saw in the health department who had had a blood clot. She had had one successful pregnancy, and nobody had really broached with her the subject of what would she do? What did she think would happen to her if she had another pregnancy? And so we had a discussion with her, and it included sterilization. So patients like that we see that would have many risks for pregnancy, we do need to have this frank type of discussion so that they understand what they're up against if they were to get pregnant again. As far as our current Title X program, we don't currently have an affordable 340B price, so I just wanted to make mention of that. And also, where Medicaid is concerned, ESSURE has to meet a prior approval criteria. I'm not going to go through all these. I'm just going to flip through these slides here. But I just wanted to make the point that one of these criteria is just one of these criteria that's required to be approved for ESSURE. Okay, Depo-Provera. Depo-Provera we're very, very, very familiar with. It's a intramuscular injection every 3 months. Of course, we've discussed often about the bone mineral density precautions, and as far as guidelines go, sometimes the fluctuations of the recommendations on calcium and vitamin D change. So I just wanted to mention that in the woman 50 and younger, the recommendations right now are 1,000 milligrams of calcium and 600 to 800 IUs of vitamin D. The benefits are obvious. This is a forget about it birth control, as Dr. Thomas says, and it's a great option for many patients in many categories. It doesn't contain estrogen. The drawbacks as far as the bone mineral density is concerned actually resolves after you stop Depo in about 2.5 years or 30 months. So I just wanted to make that point as well. All right, let's move on to a case study. 17-year-old Gravida Zero presents in for her family planning annual on POPs. Her BMI is 27. Her last menstrual period was 3 weeks ago. Her blood pressure is normal. Her meds include Trogendi XR daily and over-the-counter allergy medicine. Her medical history includes open heart surgery as an infant with a heart murmur and migraines with aura. She is currently on progestin-only pills and desires to continue. Her physical exam is negative. She has no shortness of breath, no chest pain, and no dyspnea. What is the best top-tiered birth control options for this patient? Okay, so let me back up. I'm getting ahead of myself. All right, so on this case study, I wanted to go backwards instead of forwards. She is on a Topamax derivative and product, and the point with this is that Topamax and oral contraceptives decrease the effectiveness of the oral contraceptives. We have a full list of the AEDs listed in our protocol very well and their interactions. So sometimes the birth control affects the anti-epileptic drug, and then sometimes it's vice versa. But in this case, POPs would not be a good choice for this patient. So, you could use Depo with her, you could use other methods, and Depo is actually a good one because it doesn't interfere with AEDs. Okay. All right, so on to oral contraceptives. Oral contraceptives and COCs with the risks that are out there, sometimes I think gets a bad rap as far as the effectiveness and us having to stress to our patients to take them every day at the same time. But one point of reference, just statistically, is that with perfect use, and this is combined and progestin, it's a 99.7% effectiveness. So when we're talking about tailoring to our folks, our patients, if you've got somebody that's really good pill taker and they meet the criteria for pills, this can be a very appropriate method when used correctly. However, the typical use for oral contraceptives, and that's POPs and combined, is 91%. So that leaves it with a 9% unintended pregnancy rate. Basically, not to get into a lot of detail, as far as the combined, you generally have either fixed monophasic or combination phasic. And you can have a combined oral contraceptive where the estrogen varies and the progestin is stable, but most commonly we see a combined oral contraceptive where the estrogen is stable and the progestin varies. That's what we have primarily in the health departments that we issue. The main benefit in looking at the differences is pretty obvious with POPs as far as our risk and coexisting medical conditions out there. POPs are safe, and when you're talking about birth control and wanting to make sure that our patients leave with a form of birth control, POPs, just about anybody can leave the health department with progestin-only pills. And so just wanted to make that point as far as the difference between the two. The main risk factor with estrogen that we see, of course, is blood clots. And so where combined contraceptives are concerned, we need to obviously review our aches. I think y'all do a great job of that generally as we talk about that, and so that they'll know their symptoms of possible blood clots. That's important. Okay. Within our types of oral contraceptives, you can actually give this in a cyclic fashion. We have the Seasonique and the low Seasonique in our health departments, and these allow the patient to have 4 periods per year, and it's a convenience thing, but it's also a good fit as far as our patients go for certain types of conditions like menstrual migraines. And it fits that patient very well because it avoids the cycle, hence avoiding the headache. It's also been shown good for endometriosis and can be used and tailored to those types of patients and just for preference. Some patients really like not having a period, but 4 times a month. It sounds good, to me.
You said a month.
4 times a year. I'm so sorry. I wondered what the stir was about. I'm so sorry. Yes, a period 4 times a year. No, we don't want period 4 times a month. So, okay, so let's move on to the NuvaRing. We're very familiar with the NuvaRing. We have them in our health departments. They are a combined type of contraceptive, and we leave in for 3 weeks, and then we take out for 1 week, so it covers a month's worth of birth control. It has a 9% unintended pregnancy rate. Some of the complaints we get with this is that it does cause some vaginal irritation, discharge, and that it can be expulsed. The benefits, though, is that it's not a daily routine. So somebody that maybe doesn't want depot but doesn't want pills, this is a good fit for that type of patient. Just a tailoring tip or somebody that you might want to think about as far as some of the benefits to the NuvaRing in a social kind of way. Maybe you've got a 19-year-old and she comes in and she's been carrying her birth control pills in her purse, and a coworker sees her birth control pills and she doesn't like that. She comes back and discusses that with you, and you bring up this option because this option can be discreet. Nobody has to know about this. So along with meeting the medical needs, sometimes we need to meet the wanted needs as far as what's best for that patient, and so we can have that discussion as well. Okay, let's move on to the contraceptive patch. We're familiar with the contraceptive patch, and with the contraceptive patch you place the patch each week and then remove and keep it on for 3 weeks in a row. You remove it each week and replace it with a new one, and then on the 4th week you leave it completely off for the cycle. I think one of the main things that we know about this is that studies do show a higher risk of blood clots with the patch, and most of us are aware of this. I think we should note, however, that we have had success with the patch through the Alabama Department of Public Health. So it's not intended for a first-line birth control method, but I think it is important for everybody to know that we have had some success for the patient that we need to tailor this birth control method for. Okay. With the barrier methods, we're just going to fly through these for a second. Just one point to make as far as the barrier methods go. I think, we preach condoms in our Alabama Department of Public Health. We do an excellent job of recommending condoms, whether it's for a primary use, mostly a lot for backup use. But in that, the main benefit to the condoms is that it also protects our patients from STIs, which includes HIV. And so it's something that we need to sort of stress in a zero tolerance type of way with our patients so that they use this and that they're sold on using this every single time they have sexual relations. This is the female condom. It's very similar to the male, has the same type of benefits. Spermicides come in different forms, and I'm just going to continue to flip through these and let you know that what was natural family planning is now fertility awareness methods, and you can refer to those in the handouts. Do want to touch just a second on emergency contraception. We have Plan B in our health departments. Emergency contraceptives is effective up to 5 days or 120 hours, and it's most effective when taken within 72 hours. Really, there's no contraindication for emergency contraception, but in the event that somebody was having an acute migraine, you would want to, consult with Dr. Thomas on that. Some of the different forms of emergency contraception are listed here. Our oldest form is the USP. We have still protocol that shows it's the combined. Obviously, this is not frequently used anymore. Our main type of emergency contraception that we use is the one-step Plan B. There is Ella ulipristal acetate. It is a prescription-only emergency contraception. The benefit to it is that it works as well on day 5 as it does on day 1. So that is sometimes needed or needed to be tailored for that patient. The copper IUD is a great form of emergency contraception if used within 72 hours of unprotected sex, because then it offers long-term birth control protection. If the patient uses emergency contraception, we can start their birth control the next day in most cases, unless it's depot or implant, which requires a rule out. But they should do a second urine pregnancy test in 2 to 3 weeks after taking emergency contraception, after starting pills, for example. We should, especially like with our patients who use barrier as their primary method or condoms, we should offer to our patients to have ECP on hand. So we should give those to them when they come in for their family plan annual so that they can have on hand if needed. Okay. I want to segue here for just a minute and say, what would you do if you did have a positive pregnancy test? And Title X, when they came through recently, recommended steps of counseling. So clients with a positive pregnancy test must be offered counseling on all pregnancy options, including prenatal care and delivery, infant care, foster care, or adoption, and pregnancy termination. We have very good protocol that actually discusses counseling and referral recommendations on pages 57 through 58 about pregnancy termination counseling. So I'm not going to go through the next two slides, but refer you to our Alabama Department of Health protocol, pages 57 through 58. All right. Last but not least, if you go back to the beginning where I started on all of this, we discussed in this age group cervical screening. Of course, you know, we start pap smears in this age group. But, newsflash, hot off the press, when you thought you had it down, here we go again, right? But in 2014, FDA approved HPV as a screening test. Now, we are awaiting these guidelines, but this is on the horizon, and this will, you know, come out when the guidelines are made to Dr. Thomas. So, as Dr. Thomas says, hold on, times they are a-changing. Okay, we're going to segue now into the mature woman with Deborah.
You have heard that time flies when you get older. We are really going to fly through these next few slides. We're going to talk a little bit about the mature woman. First of all, let me put that this was one of my grandmother's irises I transplanted into my garden, so it's something we enjoy. Thank you. So we do want to talk about the mature woman who's 40 to 64 years of age. ACOG screening guidelines include the usual things that we do: the height, weight, the body mass index, blood pressure. We want to feel their thyroid. We want to do a clinical breast exam, including the axillary area. We want to inspect their oral cavity. We want to do an abdominal exam, a pelvic exam. We want to inspect their skin. You know, there is a growing trend of dermatologic problems and skin cancer, so we do need to just eyeball that skin a little bit and then ask them if they would do HIV testing. These people need a pap smear if they're low risk every 5 years. If they have a high risk, if they have a high risk history of cervical cancer and positive HIV, they need a pap annually. One thing I really wanted to touch on with these women is about the colorectal screening. Remember that at age 50 and older who are low risk, they could be screened with colonoscopy every 10 years. African American women need to be initiated at 45. And on page 18 of our clinic protocol manual, it does have all of our guidelines for the FIT test and the screening colonoscopy. I did want to mention one specific thing about this is that any patient who is at high risk of colon cancer, such as someone with an inflammatory bowel disease, should see a physician for screening, or if they have a first-degree relative who's 50 years of age or younger, that puts them at a higher risk. I also want to mention that sometimes we don't think about it, but those patients that we have who come in to see us who have a history of ulcerative colitis or Crohn's disease are at increased risk for colon cancer too, and we definitely want to make sure that they're referred and get some screening. Additional health screening in this age group is that they need a fasting glucose beginning at age 45 and every 5 years. These are for healthy women who don't have any other types of medical conditions, but if they do have a coexisting medical problem, they would be screened more often. The lipid profile at age 45 is when it begins, and every 5 years after that. Mammography, ACOG recommends age 40 to 49 get a screening mammogram every 1 to 2 years. Our guidelines at ADPH recommend every year, and certainly if they're 50 years of age and older, they need a mammogram annually. We know that the average age of menopause is 52. Per the ADPH protocol, they can stay on POPs and certainly have an IUD until they turn age 55. And for Depo, they can continue to receive it until they're age 50. I want to make mention here that some women may have extended menstrual periods. If a woman continues to have a menstrual cycle after age 55, then she needs to be referred to a gynecologist for further evaluation. During these years, women sometimes from perimenopause until they do reach menopause, they'll have all kinds of symptoms, the vasomotor symptoms like hot flashes. Sometimes we have our own personal summers around our house. They can have vaginal dryness. They do have changes in their sleep patterns, and insomnia can be, can really affect you sometimes. So as far as these women, we want to remember that for hormone therapy, the rule of thumb is that the lowest doses that are effective should be used for the shortest length of time to achieve symptomatic relief of their vasomotor symptoms. I want to briefly mention the immunization that's needed for these women. They should receive the shingles vaccine around age 60. They need a flu shot annually. I also wanted to mention, which Beth is going to talk about in just a minute, about women who are 65 and older need the one pneumococcal vaccine.
So let's just segue right into the 65 and older. I think one of the main things is, to continue discontinuing Pap smears, to consider discontinuing Pap smears in women with evidence of negative history and no CIN2 or worse, with an adequate negative prior screening results that are defined as 3 consecutive negative cytology results or 2 negative co-tests performed in the past 5 years. I'm going to just flip through this. These again are the National Osteoporosis Foundation guidelines for calcium. These listing of statistics as far as heart disease being the leading cause came from the American Heart Association. You can read very much about that there. In the 65 plus, as far as the medical needs go, this is outlined all in one of our nurse practitioner articles that we have. It's by OBG Management, and it's your age-based guide to comprehensive well woman care, and is available on the document library. Okay, just want to talk a minute and say that at the end of your packet there's handouts. Title 10 recently came through, and they did a federal audit, and some of the recommendations included topics about sexual coercion. I'm sorry, I don't have that here, but sexual coercion, sexual abuse, human trafficking, victim identification. So I just wanted to make reference, this is all in your handouts. It's a part of ADPH protocol, and it's on pages 31 through 41. These are the websites for great information that a lot was included from our webcast today. And just wanted to say thank you to Wilcox County, number 1, for their involvement with the Title 10 audit. We appreciate y'all's hard work there, and they had excellent things to say about that. So thank you, Wilcox County, for your involvement in the Title 10 audit. And thank you all for all you do each and every day. And I think I love this when I saw this, because it says what lies behind us and what lies before us are tiny matters compared to what lies within us. Thank you all very much. Dr. Thomas, would you like to say anything at this time?
If I could just briefly summarize, and again, thank you both for an excellent presentation. I'm just going to touch on just a few topics that are, I think, of great importance that these guys touched on, but just didn't have the time to really expound on. And we see a lot of patients, close to 1 million patients who are in the United States who have seizure disorders. So we see many patients who are on anti-epileptic drugs. And what we need to keep in mind is that we need to know what medications, what anti-seizure medications our patients are on. And that will help us to make the best possible choice for our patients. We've got a list, as Beth Allen mentioned, a complete list in our protocol of drugs that interact with these anti-epileptic drugs, or AEDs as they're known. They're commonly known as, and they share the same pathway, the same hepatic pathway as oral contraceptives or combined contraceptives and hormonal contraceptives in general. So what happens in most instances is it decreases the efficacy of hormonal contraception. The only known exception to this is Lamictal, and the reverse happens. Okay, so 50%, in about 50% of cases, you will see a decrease in Lamictal, so that it will increase your patient's seizure risk. Hence the importance of knowing what it is that your patient is on in terms of anti-epileptic drugs. So they're good for your for your patients who have seizure disorders, and they're also excellent for your sicklers. The other and the last thing I'll mention is IUDs. Worldwide, I think they've had a much better acceptance. What we have here in the United States hanging over our head is the fact that back in the 60s and 70s, our women used the Dalcon shield, and that had a multi-filament string at the end, and set women up for a lot of infections, pelvic infections, and I think that has left a bad taste in the mouth of American women in terms of contraceptive use. So I think what we're seeing, though, especially with this push by a lot of national organizations such as ACOG, I think we're seeing a resurgence of interest in especially with our young patients, in terms of IUD use. So I think the other big shift is that both makers of the Paragard as well as the Mirena and Skyla are pushing this for nulliparous women, and that was not always the case. So I think we need to be right on board in terms of that. And I think that's it. And I know we're kind of pressed for time, so I'm going to turn it back over to Beth.
All right. Do we have any emails? You can send your emails in afterwards when we will answer those for you. No phone calls. Okay. Well, I would really like to thank the two of you for such an excellent presentation. I'm sure everyone enjoyed it, and thank you for being with us today, and come back again.